Welcome back, everyone. I'm Dr. Larry Kaczynski, one of the PTAC committee members. At this time, I'm excited to welcome 4 amazing experts for our second listening session on supporting primary and specialty care transformation. You can find their full biographies and slides posted on the ASPE PTAC website. At this time, I'll ask our presenters to go ahead and turn on their video if you haven't already. After all 4 experts have presented, our committee members will have plenty of time to ask questions. Our first speaker, we are super excited to welcome back PTAC's first Vice Chair, Ms. Elizabeth Mitchell, President and Chief Executive Officer at the Purchasers Business Group on Health. Welcome back to PTAC, Elizabeth.
Thanks, Larry. I'm really glad to be here. And I know how hard and important your work is, and happy to sort of share some things that are happening in the field that may or may not be of interest. But I'm now working with jumbo employers and public purchasers, and I can assure you that primary care is a top priority for them, as is changing the payment system to enable it. So should I just jump right in?
Yes, please do.
All right. So who are we? PBGH has been around for about 35 years. We have an average of 40 members, public agencies like CalPERS, as well as private employers like Walmart, Microsoft, Boeing, Apple. So just very large purchasers who spend about $350 billion a year on healthcare on behalf of millions of Americans. And we've had the same mission for about 35 years, which is improving quality, affordability, and equity. Next slide. One of the foundational strategies for our members, and this is based on pretty deep experience and obviously research, that investing in primary care is one of the only strategies that achieves all of employers' aims, right? So better access, better experience, better outcomes, and lower cost. There are not many strategies that can claim to be positively affecting all of those areas, but primary care is one. The other is high quality specialty care, but that's for another day. But we know that, even though primary care accounts for only about 35% of healthcare visits, it does influence 90% of spending. And unfortunately, despite its value, despite the benefits, despite employer prioritization, we typically spend about 4% on primary care. This is deeply frustrating to employers and purchasers who have been, I think, at least in the last several years, very clear that they would like to see greater investment in primary care. When we measured on behalf of our members, the average was about 7%. They are actively putting into their contracts that they would like that amount to increase, their contracts with health plans and their direct contracts. And I think this is an important piece of context, so bear with me for a second, but I also sit on the board of the Office of Healthcare Affordability in California. And one of our commitments is to increase the percentage of total spend into primary care up to 14% in the next several years. So there is growing recognition of the need for this. Unfortunately, we're not seeing the rapid transition we would like to see. So again, one of the, if you're just even looking at ROI from an employer perspective, which at least my members don't look at it that way, but there's a 13% savings for every dollar spent. That's, again, it is just a very high impact investment, and there is deep recognition of that. Next slide. Conversely, there is a pretty significant downside of not investing in primary care. And when you're looking at it again from a large employer perspective, you lose time and there's additional cost, and there's a higher total cost of care when they aren't treated in primary care initially. Going way back about 7 or 8 years ago, PBGH was involved in a CMS program. We worked in California with even small rural practices, And with the right technical assistance and payment changes, we were able to quantify over 50,000 avoided hospital visits, over 60,000 avoided ED visits. And again, this was all from giving primary care the right tools, the right data, the right staffing, and the right payment. So I think this has been demonstrated over and over, both in other countries, but also in pilots across the US, that this is the right investment. Unfortunately, it just hasn't scaled. Next slide. So what I'm going to talk about is sort of two things. One is the PBGH's sort of national work around advanced primary care, as well as our deeper work in California through our technical assistance team called the California Quality Collaborative. They work directly with practices. And so we have sort of two initiatives that have been very high priorities for the members. And they both also are related and coincide, but we started with sort of what are the key attributes that we're trying to achieve, right? It is, access the way patients prefer. We know we need interdisciplinary care. One example that I'm going to come back to again and again, integrated behavioral health is a top priority for our members. That requires an interdisciplinary team. Patient care is beyond the chart. We are absolutely thinking more broadly than what just happens in the primary care visit. How do we deal with social needs? And I was when I worked at Blue Shield of California, I was part of an initiative where there was social needs screening in practices. But one of the takeaways was that they're doing the screenings, they're finding these needs, and then the clinical team didn't know what to do with them. So there was an expansion to community health workers. So again, just thinking more broadly than the traditional teams is very important. And then it's obviously got to integrate with the rest of the system. So again, I don't think any of this is terribly controversial. It's what everybody wants, but it is not typically reflected in most primary care. Next slide. So we started out with, once we had really clearly established the priorities, like what we wanted care to look like from the purchaser and partner point of view, how would we measure it? How would we know that we had it? And how do we translate that into measures that could be integrated into contracts? So we came up with a common measure set. Again, this was meant to be not rocket science. These are not terribly controversial measures. But they were meant to be consistent and parsimonious and evidence-based, obviously. So again, I'm happy to share this with you. I know this is very small font, but we looked absolutely at outcomes and prevention. So are they even able to get in and then get the screenings and the care they need? We highly value and prioritize patient-reported outcomes. I understand that the methods for measuring patient outcomes have been around for decades. They have not been taken up by the industry for the most part. In fact, in California recently, we went backwards. We stopped doing patient-reported surveys. So we know that this is a critical component, not just for employers, but for patients. And frankly, it is one of the best ways to get at equity because you're actually asking the patient and they are giving you their feedback from their perspective. So depression screening for adolescents and adults, but then we included depression remission because it's not enough to do a screening. What is the patient's health and is it sustained? Patient safety, experience, and high-value care, so emergency department visits, inpatient acute hospital utilization, and total cost of care. And I appreciate that the total cost of care measure is sometimes controversial. I will say from a purchaser perspective, it is non-negotiable because our goal here is not to save money by doing the wrong thing, but it is absolutely to make sure we are doing the right thing. And we know that investing in primary and preventive care and being willing to pay more for primary and preventive care typically reduces total spend. So we believe these things are intricately linked. And it's very important that we are not paying more for worse care. It is about paying for the right care. Next slide. So one of the things that we did was after we we got consensus on measures. We started integrating them into health plan contracts, and we obviously partnered with providers to do this as well. And the key feedback we heard is that, yeah, we would all love to do these things, but the key barrier is payment. We are not paid to do the things you are asking us to do. So no surprise, we know, fee for service and 15-minute visits don't get us there. If you're not paying for, behavioral health screenings or community health workers or all the things that actually improve health, it's not possible. So we actually know that payment is the primary barrier, and our members set out to change that. And in their contracts, they are demanding that we have alternative payment models, specifically prospective population-based payment models, so that practices have the flexibility they need to provide the care that everybody wants. Our members are also really clear about the fact that advanced primary care, as they define it, includes quality-based specialty referrals. We know that that is one of the key approaches to both outcomes, experience, but also total cost. And we also know that quality varies wildly, so there has to be a way to ensure that when a referral for specialty care is made, it is done taking into consideration the quality of the provider who is receiving that referral. I am well aware that that is challenging. I am well aware that most primary care providers don't have that information. I am also well aware that quality-based referrals bump right up against a lot of business arrangements in health systems. That's why our employers want to do it, because someone has to drive that on behalf of employers, on behalf of patients, sorry. So we know we want to pay for a team, pay for the data and analytics needed to manage population health. We need to hire the community extenders that make this possible, that go into homes and into communities to actually meet patients where they're at, integrate mental health, and pay for physical therapy, particularly for our manufacturer members like Boeing. They know physical therapy is a key need among their population. They want that integrated into primary care, and they are willing to pay for that. Next slide. Unfortunately, even though we get a lot of consensus among our employer members about the standards that they would like to see, when this goes through a bunch of health plans to administer, it often gets lost in translation. So all of these plans have slightly different approaches. And again, no shade on any of the specific plans, but if every health plan has a different measure set or a different denominator or a different payment model, that does not make it easy for practices. There has to be alignment so that they can actually make the change for everyone in their practice across their population. Next slide. So what our members decided to do when it was really challenging to get that alignment, many of them just decided to direct contract. And that is not new for our members. They've been direct contracting for decades, but there was a specific focus on direct contracting for advanced primary care. We have recently launched a very significant initiative in Puget Sound, where they are directly contracting, using the same measures, using the same contracts, and using the same payment model for primary care. This is a new initiative, but it's with 3 jumbo employers, so it was not just one employer asking for this. We know we have to align on our side, but we've got 3 very large employers, including Boeing and eBay and another that I'm not at liberty to name, but it's really big. And they are saying, these are the things we want. We will pay you more. We will pay you differently. We will make it flexible, but we are going to hold you to the same standards to make it easier. Next slide. So in California, we took a somewhat different approach because we are trying very hard to align also with our health plan partners, because we know jumbo employers, first of all, they're not jumbo everywhere, so they can't drive every market change. They typically have very small benefits teams. They need their health plan partners to do this. But what we had to then do the work in California to sort of get the health plans to align. I want to give a really big shout out to Blue Shield of California, who I know is there, who really helped us drive this work and helped us enlist plans. But we had 7 health plans step up and say they wanted to do this with us, which was really gratifying. It ended up being 3 who actually went forward with the aligned payment model, but at the same time, we really have been really appreciative of the partnership and the readiness to change. So we started with that measure set that I showed you, and we worked with practices, and then we went the next step in California, and there is hopefully a summary of this initiative that will be shared with you. I sent it along, that showed that by aligning these, like even 3 health plans doing the work of aligning can actually really drive change. Next slide. So we made clear from the outset that there were a few key tenets of this work. Again, we have the measures that we want to achieve, and we have the partners lined up to do it, but we really wanted to be sure that we have transparency. We've got to be able to see and know the outcomes. We've got to invest and actually pay more for primary care, and we've got to have value-based payment. And that we have to also provide practice transformation, because the changes we are asking for at the provider level and the practice level are significant. So we had the grand signing of a memorandum of understanding to do this together. Common quality measures, increased investment, shared technical assistance, and clear and aligned performance incentives. So this was, I think, a real breakthrough and really quite exciting. Next slide. So what is the common value-based payment? Well, payment for direct patient care using a mix of capitation and fee-for-service. We're tentatively calling this fee-for-service plus. That will be one option, or PMPM payment to support population health management, and that's up to a 15% increase. And then performance-based payments based on the standard APC measure set, so the measure set that I referenced earlier, and an upside of up to 15%. So again, none of this is radical, I don't think. None of this is, it's all evidence-based, and it's been demonstrated in various pilots that this works. But the idea was to try to scale it at least across 30 practices in California. Next slide. By the way, sorry. Well, I can say this here. One of the things that was actually another key enabler of this was a common reporting platform. And we partnered with IHA in California, the Integrated Healthcare Association, who does collect this data, who does have a common reporting platform. So when you think about all of the basic infrastructure pieces needed for multi-payer payment reform that just don't exist, this was a key example, right? There's no common reporting platform where, measures are collected in a standard way. And we are fortunate in California to have IHA as a partner who can do this. So again, there are so many missing building blocks, but we are able to sort of overcome those barriers with partners like this. So what are the things we're asking for? And then I'll wrap up. Join this work, like align with the payment model. You can, in California, we also have IPAs you have to sort of enlist, and just align your incentive programs with the APC measure set. We've all got consensus that these are the right measures. This is what matters. So how can you, from whatever contracts you have, move towards alignment? Again, those IPAs need to have a challenge, but we are asking them to also align their payment model and their P4P incentive programs. And then what we've asked our purchasers is really engage in a collaborative dialogue with your plans and practice partners, understand what the barriers are and help overcome them. Again, I can speak for our members. They would like to see change, but they're also willing to participate in that. If you need a contract change to allow you to do this, tell us. There is a readiness to make these changes. Identification of multi-payer collaboration as a key aim here. Understanding those operational hurdles. I worked in a health plan. Those legacy fee-for-service systems are not designed for this work. Okay, so there's an operational barrier. How do we get around them? Plans are finding new startup partners who are able to enable different types of payment models, but we've got to overcome these legacy barriers. Recognize the time, resources, and adaptations needed. This is not easy. This is sort of no one's day job typically. And then realistically assess the feasibility for the pace of change and recognize this might take a 2 to 3 year contract or amendment, something. We know it's going to take time, but we need to start. And then really incentivize collaboration, or at least remove the disincentives to collaboration. So these are some of our key findings. Happy to answer any questions.
Thank you, Elizabeth. It's so nice to hear your voice again. Next, we're excited to welcome Dr. Joe Kimura, Chief Medical Officer at Somatis, and we are especially fortunate because he's here in person. Please go ahead, Joe.
Thank you very much. And thanks to the committee for inviting me to participate in this panel. And it's a privilege to be here, and I really look forward to the discussion as well. So I think I've got control of the helm here. Just briefly, I think after Elizabeth's presentation, I'm thinking what my position is and what my role would be in terms of reflecting and opining to the committee. And I think my role is as a provider and a leader who has been working in various levels of delivery systems, from highly structured, fully integrated systems towards partially integrated systems to where I am today, where we are a specialty-based VBC, if I can call them provider adjacent to provider supportive organization. Somatis is just an organization that cares for patients with CKD, but takes total cost of care accountability for that particular population. So I'm a PCP by practice, and all of you know that once patients get over a certain age, almost everybody has CKD. And so that morbidity of the population is the population Somatis cares for, and does that from a vantage point of working alongside providers in the community, as well as health plan resources to try to drive accountability and outcomes. So quickly, prior to coming to Somatis in 2022, I was at an organization called Atrius Health, Harvard Vanguard Medical Associates. We were one of the original pioneer ACOs, stuck with it all the way through shared savings, as well as one of the original participants in the Blue Cross AQC on the commercial side as well. And because we were an organization that was fully capitated for over 80% of our revenues, 50% of our patients, 80% of our revenues, managing in this space across 32 plus specialties was one of the things that I experienced firsthand, both as a practicing PCP, as well as an administrator. And so hopefully we'll bring that perspective in. The other side of my world, and this is sort of a commentary of the prior panel conversation we had, I'm boarded in clinical informatics. So my whole world in value-based care and thinking about how informatics and analytic capabilities can help transform healthcare has been something that's been dear to my heart for 20 plus years. And again, has serviced me well, I believe, as we're practicing in all of the different settings that I explained. So with that, let me jump in first and say, thinking about primary care and specialty care collaboration and how to promote that a little bit more, I always like to think through and say, well, what are we talking about there? What does that really look like? And fortunately, rather than opine from my own perspective, I just brought forth ACP's 2022 sort of policy paper that said, in order for primary and specialty care to collaborate better, there's 4 principles that they'd submit: patient, family, partnering, define clinical roles and responsibilities, timely, productive communication between the specialties, and of course, effective data sharing. Now, those of you who are familiar, and I'm assuming many of you on the panel are familiar with this report, there is a 33-page example document that goes along with it that goes into a lot of details that I feel are very appropriate. I find myself as a clinician saying, yeah, these are the challenges we face when we have patients with CKD 4 or 5 with lots of behavioral health, as well as obviously nephrology concerns. And I as a PCP, need to manage that. I can't just give it all to the nephrologist. Nephrologist can't punt it all back to me. So how does that work? I think the ACP document highlights some of the core areas of what generally needs to happen. And a question I believe the panel is asking us, well, how do you make that happen more robustly and more reliably and more effectively? So I took the liberty of just taking one step back and saying, from my experiences, this is how generally, and I will apologize, a very rudimentary schematic in terms of my PowerPoint skills, but thinking about how do you get multiple people on a team to drive towards achieving a particular performance on an outcome KPI? And this is not an uncommon structure, right? Where you have, as you might imagine, on the left-hand side, provider A, driving things maybe on case finding and sort of initiating that process, but then multiple specialists or other providers starting to be participatory in terms of closing those gaps. Then ultimately the PCP starting to come back in and saying, how do I wrap it up together and have the communication? Now, all of these folks are involved in driving performance on that end KPI. So how do we try to get everyone aligned? And when I reflected upon our experiences in the various organizations, I would postulate that there's 5 areas that this panel has probably spoken about ad nauseum, but I'm going to highlight for the group today. And the first is aligned clinical culture. I know culture is always a hot button topic, but I do feel like what I mean by aligned clinical culture is that there needs to be general agreement upon what is the best clinical practice among primary care and all the specialties. And I would actually extend that to say all the care team members involved in that care for the patient. It's easy to point to evidence-based guidelines that are published and say, of course, we're all following our specialty guidelines. But as many of you know, too, sometimes there's discordance. Particularly, I'd call attention to things like mammography screening or Pap screening when the generalist guidelines and the ACOG's guidelines started to diverge a little bit, adds to a little bit of tension in that space. But in general, thinking about how do you align across that clinical culture is kind of a prerequisite because it creates that foundation for everything that starts to follow after it. And that second one that I think is equally important and probably more so now, given the stressors that all the clinicians and all the care teams are facing, is an aligned clinical operational system. And this is where I would point to all the point of care decision support, all the EHR configurations, everything that allows those workflows to go smoothly. That needs to then also be aligned, because the last thing that I found that you need is certain configurations firing at one point, driving certain decision support rules, conflicting with what the PCP or the specialists are saying. When that happens, then you automatically place clinicians in conflict with one another, and they're trying to figure out, how to actually navigate that. The third is probably one of the most, I would say sort of easiest to understand, but probably one of the most difficult things to try to do today is to make sure that throughout that entire process chain, you have clinical informational continuity. And we talk about interoperability. We talk about the fact that we are promoting it, but I think everyone in this room knows we are still stuck at higher levels of interoperability and not at the semantic levels that really are required to make necessary decision points as you're passing from the left towards the right. Again, timeliness of this is also an important one area. The example that I always give is post-discharge. There are about 30 people jumping in on that patient, trying to figure out how to actually make sure that a readmission doesn't happen. When that happens, that trigger, whether it's an ADT feed or some other flag, some of that information comes. We have found in various organizations that it doesn't help as much when it comes 14 days post-discharge. And again, one of those areas that everyone knows what should happen, and yet it still seems challenging for us in today's environment to make happen. Fourth one is transparent performance management. And this one, I'm going to put my manager and administrator hat on a little bit. And this is where sometimes we tend to blind and work in a space where we say, I'm just going to give a particular physician their particular feedback. And I'm actually going to expand it. It's not just physicians, it's nurses, it's pharmacists, it's everyone on that care team. How do we make sure that those clinicians are getting that information, not about their own performance, which is always critical, but overall that entire process, and say, where is that process falling down? Who's actually accountable for that? And this was easier to do in certain settings, harder to do in others, but I would say collective pressure or collective desire to improve care for the patients leads to some great performance outcomes. And then finally, something that I think is, of course, the core to this committee, aligned financial incentives. And I would say that it's not just around the incentive structures of penalizing or rewarding. I would say that it's very core to the core compensation model of the specialties in primary care that needs to complement that, because I've seen in many examples incentives just become completely neutered when that core model is not following suit. So a couple of core concepts. And if I were to then take 2 steps back, and I added a little bit here at the bottom, and I apologize, the font got super small. Not only are the physicians and the clinicians doing this, there are usually care teams in addition to this, right? Particularly in the world of population health management. Not only does the primary care clinician have them, in my current role in Somatis, we complement our nephrology specialty colleagues providing that service. And usually the health plan is also jumping in with a care plan along those lines. All in the services of dropping the readmission rate, improving the HEDIS scores or the STAR measures, you name it, all the accountability is there. How do you actually bundle all of this together? And if I reference back to the 5 points from before, and I refract them through either a really tightly integrated system like Kaiser Permanente, a partially integrated system like Atrius Health. And Atrius, we just had the outpatient side. We were not connected with inpatient, either hospitals or skilled nursing facilities, or a provider adjacent or a provider supportive model like Somatis. I put forth sort of the elements that are there mostly because as a executive in an organization like this, you have lots of levers that you could pull, and you want to pull all of them to try to promote the fastest, most efficient way of getting to those KPI outcomes. It is much easier to do when you control that entire spectrum of things. And I think on the prior panel, we're hearing from organizations that also had those kinds of controls and abilities where they controlled the entire informational control stream. They actually had employed and non-employed physicians, but also had that system from outpatient to inpatient all the way through. As you start to drop down and as the system becomes, if I call, more loosely integrated, I do believe the power, even though the core interventions across remain the same, your ability to impact or pull that lever as hard as you want it to starts to get harder and harder and harder. Whether it's the data side of it, obviously the compensation side of it, or even the clinical culture side of it, it becomes harder because, again, that locus of control starts to get looser and looser and looser. That, however, does not mean that it's impossible to do in these settings. I truly believe, and my experiences in Somatis over the past 2 years have demonstrated, you can move the needle tremendously well as long as you're focusing on those 5 things and trying to provide the level of support. It is harder, I will say that 100%, when you don't have these things fully in your control, but that doesn't mean that it doesn't work. And if you find creative ways to do it, you can bridge. So with that, how do you then say, if that's the how do you incentivize it? How do you grease the skids? How do you make it work better? And when I was pulling through, most of the panel probably goes to where I went originally. There was an article by the late John Eisenberg and Peter Greco in the New England Journal in 94, that talked about changing physician practices, right? But that was 93. So look back in the literature and said, what else is there? What other kinds of reviews have been done, particularly in the age today where there's a lot more informatics capability coming through? And the folks at McMaster University, Dr. Bondardi and the colleagues in 2015, still a little bit old, but pulled this together to sort of look at the literature and say, what are the elements that start to facilitate better team-based care across primary care and specialty care? And this list is probably not surprising for anyone on the panel or in the listening audience, but I wanted to highlight some of the things in red that are probably getting a lot more play today. And perhaps some of the things like printed educational materials may or may not be used as much today, even though they were obviously assessed in that particular review. I do believe there's a lot of these levers that one can pull. One of the things that came out of this particular paper, clearly, and again, lots of face validity, multifactorial interventions are clearly superior to any one of these at any particular point in time. And that was something that Dr. Eisenberg and Greco also mentioned almost 20 years ago. But here's the thing, and as I sort of pull forth and say, all of that literature is great. It's like going through and saying, bless you, pulling through John Cotter's Stages of Change, and you're trying to figure out how to apply it. In reality, I have found that it's challenging to help bring these changes forward, in particular because I think our clinician workforce, in today's world where there are so many competing demands, requires something a little bit more than just pure dollars or operational change. And this is an old paper, I think it's 1983, coming from Andre Delbecq, who talked about justice as a prelude for forming teams. And the concept here, for those that have not read this paper, is really talking about the fact that, look, physicians and clinicians truly have the patient's best interest in heart. And at the end of the day, there's a desire to say, I'm thinking about the best interest of that patient. And it tends to pull apart rather than pull together when things get really stressful. But what they have found, and again, I still find 30 years later that this tends to be something that I found again and again in all the settings that I've worked in. If you are doing this together and working with the providers in the front lines to say, here is what we're trying to achieve collectively, and that requires transparency. It requires having information across the entire process, and then visibly processing that, the pros and cons of a particular change with them, can start to lead towards more commonality and a decision to be able to say, yes, let's all move forward. And in a sense, his last line here is, in a sense, justice is substituted for cohesion, which as a management person, I would say, I'm going to take that as I'm moving along because I'm held accountable for measures to perform every 12 months. And I don't have 5 years to help them actually get to the place they need to be. The applied example of this for me was at Atrius Health. And at Atrius, because we were capitated, we had a particular physician compensation committee that brought together all of the physicians in representation of probably 12 to 13 of the specialties. Our lab and radiologists, our surgical specialties, med specs, primary care had disproportionate, internal medicine, pediatrics, et cetera, came together with our HR and finance colleagues each year to set the compensation model for our clinicians. And that conversation was probably one of the most important things that led to the buy-in, particularly when we knew we were actually about to go into a new ACO contract with 25 new accountability measures that no one was going to want to actually change their Epic clicks and all that stuff for. How do you actually get everyone to that space? And that collective conversation, we always took heat from the community saying it was kind of like a socialist compact, but we actually turned around and said, look, radiology knows that primary care for a capitated organization is the driver of revenue for the organization. Therefore, even though it's hard to recruit radiologists or dermatologists, substitute high-paid specialty on the left-hand side, we had to somehow figure out how to share that pie, given how the economics of the organization worked and how we needed to split that through to try to make sure all the specialties were supported, because it was a team game. It wasn't that if primary care lost because they couldn't hit all the quality KPIs, orthopedics lost. So how do you actually link everyone together? And that was a brutal conversation at times, particularly around COVID when everyone was hurting. But at the same time, I think some of those areas allowed the process and that forming of justice that allowed the organization to push forward and to be able to actually drive the changes that we needed. And I'll conclude with two things. One is something that probably this committee is, and everyone is very aware of. The burnout problem, if I can call it that way, is ubiquitous and continues to be a challenge across not just clinicians, but all staff members in the healthcare team. When we think about that and think about all the challenges and the root causes for that, throwing money at folks is probably not going to be sufficient to actually help overcome some of these things. And we're seeing it too. I'm sure all the organizations are seeing it, particularly as a newer generation of clinicians are coming through. There is a trade-off, right, in terms of time and money. And you can't sometimes pay more or pay enough to be able to overcome that aspect of trying to figure out how do I balance this. And lots of folks have jumped in. The AMIA in the informatics community has actually driven the desire to drive documentation burden down to 25% of where it is from current state in 5 years. I think there's a long way to go in terms of that, but also making things easier for folks to do the right things consistently. So in that, I always want to end with a positive story. And so I pulled 3 examples on literature. And again, even though the original publication comes from integrated delivery systems, I would say that these concepts are expanding and I've seen replicated in looser systems and even academic medical centers. So the complete care program at Kaiser was something where it is a remarkable thing if you've seen this actually in operations. And Mike Cantor used to run quality, had published on this back in 2014, I think. But it is the concept where the entire system leans in to begin to say, when you're actually thinking about getting a mammography or colonoscopy or getting someone checked for an A1C or their retinal eye exam done, you need to leverage every contact in the system, whether it's the PCP, the orthopod, the hospital, the urgent care center, even the skilled nursing facility. All those touches gets to lean in, and it is all about trying to be sure you're not slowing down that dermatologist or throwing down that orthopod. But when you create a system where the incentives are aligned, the informatics are supporting it, you lean in, you can start to get tremendous performance. And that was in 2014. If you look at some of their literature today, it's actually pretty impressive where they've gone. The second example is SureNet. SureNet is something that Kaiser started, but again, in Boston, we started to do this, and Brigham and Women's has actually advanced this as well, too, where you're thinking about using automated systems, right, to be able to screen and create capacity, whether it's AFib or prostate cancer screening or other areas. You basically allow the urologists and the specialists to use the same data the primary care is using, and you begin to automate those referrals forward, again, because there's an agreement around whether or not if, and again, the example in this paper was specifically around PSAs, where they were saying if there is a PSA that's highly elevated that everyone agrees needs follow-up, and yet there is no follow-up that is seen in the system in 12 weeks, then we have all agreed that urology is not going to wait for the PCP to create that referral. We're all agreeing we're going to pull that person into referral. I have 1 minute remaining. Last example, Geisinger's Ask a Doc. And I think this is an example that all of us have seen, particularly post-COVID. So e-consultations, what does it do? What does it help? It smooths the aspects of communication between primary care and specialty care, particularly in the outpatient space where it's hard to do curbsides when everyone's in separate buildings. But that capability was demonstrated at Geisinger to significantly reduce unnecessary ED use as well as total cost of care reductions. So I think there's examples that are out there that show this, and it starts and it's almost always published in these integrated systems because they have all the systems, the tools, the capability. But I would encourage the panel to say many of these examples 10, 15 years later are starting to diffuse out into loosely coupled systems with equal success. And I think it's something that should be promoted and allows all of us to provide better care for our patients. And I think I'm going to hand it off to Rob.
Thank you, Joe. Thank you so much. Next, we are happy to welcome back Mr. Rob Mechanic, who is a senior fellow at Heller School of Social Policy and Management at Brandeis University. He's also executive director at the Institute for Accountable Care. Great to have you here, Rob. You have two to follow.
Okay, well, thank you so much. Thank you to the committee for inviting me, and it's great to be on a panel with such esteemed colleagues, several of whom are good friends of mine. If we go to the next slide. So the question that I was asked to address was, what are specific approaches for nesting episodes of care in total cost of care models? And this is something that we've been talking about a fair amount for the last 3 years, started with a blog by the folks at CMMI, and the conversations continued. But the discussion's been mostly conceptual. There's sort of been very little concrete discussion about how would you actually do that. So I'm going to spend a little bit of time talking about how might you actually do that. I love Dr. Kimura's discussion because I think the concept of using episode frameworks to look at clinical care and to redesign clinical care makes a whole ton of sense. But I'm going to also raise some cautions about trying to impose an episode financial structure on top of a financial structure that is already there to manage total cost of care, some of the challenges that would need to be overcome to really do that well. So if we go to the next slide. So this is not so dissimilar from the concepts that CMMI raised several years ago, which is, well, what are some strategies to do this? So one is you could provide data, and you could say, hey, ACOs, use this data and develop some protocols and incentives inside your system. So this is sort of the concept of shadow bundles. And CMMI did provide what they called shadow bundle data to the ACO community. The shadow bundle data was only for the ACO beneficiaries. So for many ACOs, and I'll show some information as we move along, it wasn't a whole lot of volume or sample size. So it makes it much harder to draw conclusions from the data that they're looking at. So second piece would be require ACOs or encourage ACOs and their providers to join bundled payment models. ACOs have always been able to do that, but participation in the federal bundle payment models has really sort of cut back from a few years ago because of the imperative to make it, savings for Medicare. So not a lot of ACOs are in bundled payment models. We do now have a mandatory model team that's going to start next year. And so about 1 in 5 ACOs have a hospital that will be part of team. And I actually think it could be beneficial in driving integration between the ACO and specialists and hospitals. So another idea raised, set condition-specific benchmarks. Again, this is something that Joe talked about a little bit. Or I shouldn't say, Mike Barbotti talked a little bit about this working with one of their renal practices. So one of my questions here on the condition-specific benchmarks, you can envision a collaboration between ACOs and hospitals or specialty practices, but my question is it going to be a zero-sum game? So if you nest episodes inside of total cost of care, can it be a net win and not a net loss for somebody? Because if you make it a net loss for somebody, it's not going to go over all that well. And so where is the balance between the opportunity and the risk when you already have risk? How do you make this into a win-win approach? Another idea, structure some kind of a medical home type of approach. And we have had primary care medical homes nested inside of ACOs, and that seems to make a fair amount of sense. But do something more like a specialist medical home with incentives for longitudinal specialty care management. And that I would envision as something a little bit more like a guide model, where there's not necessarily additional risk, but there are additional resources for programs that have met a set of criteria to manage a particular population and sort of jumpstart some of that really focused specialty care management. And then, the last kind of related question is how would you reconcile if we're going to nest bundles as a payment model into a total cost of care? How do you reconcile that as shared savings? And historically, that's been a real bugaboo for CMS. It's been very complicated. People don't understand it. It's easy to make mistakes. There are distortions. And so much so that for the team model, they said, we're going to throw that out. We're just going to reconcile the programs separately. We want the ACOs to participate. We don't want to drive them crazy with some complex reconciliation, so we're going to keep that separate. So that's, I think, a key question going forward. If we go to the next slide. I think episodes have a lot of benefits, but they also have a lot of challenges. The first is if you are trying to measure episode performance and you don't have a lot of volume, you're going to see a lot of random variation. And if you have a lot of random variation, what that means is that randomness could affect your gains or losses more than actually clinical performance. And so some people who are doing nothing could make money. Some people who are doing really good work might not make any money because of random variation. So you have to focus on bundles where you have big volume. The second issue is risk adjustment, and risk adjustment is hard to do. I mean, it's hard to do everywhere, but it's hard to do in episodes. And risk adjustment can be reasonably good in procedural episodes. Acute medical episodes, it's much less, the predictive power is much less. And when you get into the chronic condition episodes, it becomes very hard to do. Provider attribution is important. The concept of team-based attribution that Joe was talking about, I think that's really important. But sometimes identifying the right specialist. Sometimes you have people who, they get specialty care in a hospital. They haven't seen a specialist. They're hospitalized for heart failure. They've never seen a cardiologist. So how do you think about that attribution? And then finally, when we talk about longitudinal episodes, how do we define the episode? Because in Medicare, people with heart failure also have chronic kidney disease and hypertension and diabetes. And so what are we measuring? Is it a capitated payment, or are we somehow carving out heart failure related costs, and how do we define those? So these are all things that make this enterprise a little bit more challenging. We could go to the next slide. And I'm not going to spend much time here, but I think the opportunities for ACOs, one is to help the primary care providers make better referrals. The second is to get the specialists engaged in value-based care management and sort of understanding what the ACO is trying to do. And the third is effective collaboration. And I think, again, Joe laid this out very nicely. There are a number of tools for improvement. You need data because, my friend Gary Kaplan used to say, make the invisible visible. And a lot of this stuff is invisible. So you need to start with data. But then in my mind, it's really the culture, you need to start with strategic alignment from leadership. So the senior management and the clinical leaders have to want to do this. And they have to believe in it. And then, come down to the organizational culture. You need docs who believe in it and champions. You need systems that make it easy to do the right thing. And incentives can be important, but the incentives are probably the last thing that I would worry about. I sort of worry first about the clinical enterprise and the culture and the leadership to really make this happen well. So go to the next slide. So why is it complicated to do this inside of ACOs? And there's really four things that I'll talk about here. One is fragmentation of care, because I think there's just a lot naturally. The second is that most of the specialty care received by ACO patients is not provided by ACO specialists. They're outside specialists. The third is that many ACOs, they range in size from being tiny to huge. Some of the huge ACOs are very geographically dispersed, so in any market, they're really not that big. And many ACOs have not a lot of volume in episodes because they've got healthy people and sick people, as opposed to hospitals that are really treating exclusively sick people. So, and the last thing I'd raise is that many ACOs have a limited power base. The people in a health system who are driving the revenue are the specialty practices and the hospitals. And so some health systems have really embraced value-based care, but there are plenty of them who maybe have sort of embraced it a little bit. And, they have ACOs, but the ACOs are not the power base. They don't have the resources, and they can't make all of this happen. So in terms of fragmentation, what's an ACO? It's a lot of different things. And so this is just breaking out in deciles the average number of physician groups per ACO. And as you can see, the average is 34. Sometimes they come in, many of them are on different electronic medical record systems. Many have different culture. And so kind of organizing around specialty care is more complicated in that sense. Go to the next slide. So here, what we did is we looked at the Medicare claims data and we split ACOs into four groups, what we call PCP focused. At least half of their providers were primary care providers, primary care oriented, specialist oriented, and specialist focused. And the specialist focused, probably between 2/3 up to almost 80% of the providers on the ACO list were specialists. And looking at the percentage of primary care provided by ACO practitioners, which is a majority, and now looking at medical specialist care and surgical specialist care. And so this was our analysis, but Michael Barnett and Mike McWilliams did a very similar study they published in AJMC. And so it's just a lot of the specialty care is outside. And again, it can be very fragmented. Go to the next slide. In this slide, what we did is we looked at ACOs in 2021. I think there's roughly 460 ACOs. And we said, how many of those ACOs had patients who would have triggered these different BPCI advanced episodes? And so you have, most ACOs would trigger 100 pneumonia, 100 joint replacements, 100 sepsis. Now we're down to less than half have 100 heart failure episodes, and now we're down to 30%, 100 stroke, and the numbers just get smaller. So the volumes are relatively low. Now, if you said, let's take ACOs and let's look at their hospitals and how many bundles did their hospitals participate in, the numbers could be higher. But for the ACO patients, the sample sizes are often low. And if you go to the next slide, what are the implications of this? And here, this is kind of a complicated slide, but I'll try to explain. What we did is we looked at 90-day Medicare episodes for heart failure, acute heart failure hospitalizations. And we did something called a bootstrap simulation. So we essentially created this big pool of episodes from a very large market, and then we pulled out 1,000 random draws of 50. And we said, what's the average cost of the 50? And you can see the range here for the groups of 50 was the average cost was between $34,000 and $23,000. Now, as you go to 100, 150, 200, the range gets more and more narrow, but there's still a fair amount of random variation. And so that's one of the challenges here is if you're looking at small numbers, are you getting an accurate sense of what the costs actually have been? So if you go to the next slide, we've done some surveying of ACOs and we asked them to report their barriers to specialist alignment. So, the first one is lack of data and especially lack of quality information to evaluate specialists. Cost so-so, but quality, they really felt like their bucket was empty. I think that the ACOs were concerned that fee-for-service is really driving the specialist behavior. That if they were small and lean ACOs, they didn't have bandwidth to go out and do all of the, for lack of a better word, academic detailing or engagement activities to start to bring the specialists on board. That some specialists were interested in value-based care, but others aren't. And finally, sort of an uncertainty about the financial incentives, and particularly, if you get a high-paying specialist, you want to get them to pay attention, you have to pay a little bit more in terms of bonuses than for a primary care physician. And I think there's some concern that if ACOs start to do this and build in big specialist gain sharing, they could potentially dilute the shared savings that are available for primary care. And, primary care is still the core of many accountable care organizations. So I will wrap up here. If we go to one more slide, my conclusions. I think if possible, CMS should share more episode data with ACOs and ideally all Medicare data, including Medicare Advantage. I know that's probably not reasonable now, but it's a goal to work towards. The second thing is I talked about power dynamics. I think that we need to think about incentives for specialists and hospitals to engage with ACOs. So don't just put the onus on ACOs. You got to go out there and engage the hospitals and specialists. What could we do to make the specialists and hospitals say, hey, it would benefit us to work with ACOs? The third is the mechanics of nesting episode payment models. I think haven't been worked out and are probably going to be challenging. And then finally, I do love this idea of nesting a medical home approach with incentives inside of an ACO, using something like a guide model where you have ACOs who have programs that are reviewed, that need some additional support, providing some additional support, and then kind of tracking what the outcomes are. So I will pause here and pass it over to my esteemed colleague, Dr. Opelka.
Thank you, Rob. Next, we're excited to have a previous PTAC submitter of the ACS-Brandeis Advanced APM model, Dr. Frank Opelka, who currently is Principal Consultant at Episodes of Care Solutions. Welcome back to PTAC, Frank.
Larry, thank you so much. And it really is a pleasure to join this panel. It's been amazing to listen to everybody today. There's been a lot of these presentations have talked about the current horizon and what's on the immediate next horizon. I'm going to push a little further down toward perhaps the third horizon, but all of these are moving together and all of these overlap. And I think there's a lot to share. And I look forward to sharing that with you now. So next slide. These are my disclosures. I continue to work with the American College of Surgeons, and I'm working with KPMG on Medicaid and episodes of care within the state of Colorado. And I've got a lot of grouper experience with the Patient Center grouper, and those are the major disclosures. Next slide. So as I look at this, and as a specialist throughout all of my career, the best outcomes I ever had as a specialist taking care of patients are those patients who had outstanding primary care. That those patients came to me and they were in the best of shape or had the best opportunity. And so when I look at this, I really value primary care greatly. And how do we actually take a different approach from the approach that's been emerging over the last several decades to get the best practices within integrating primary care, and especially team-based medicine. For the longest of time, we've grown up in medical schools where all of our education has been extremely siloed, very transactional, and not built all of this together. Yeah, there's a lot of holistic conversations that talk about it, but when you get down into the field and you're doing the work, you don't quite walk the talk. So I think there's a lot to think about in how these organizations are performing, what we can do with, everyone's already mentioned, data sharing, and how that becomes an important part about all of this to getting toward more effective care. Next slide. It amazes me that we've got in many hospital settings 300, 400 measures, and still I get the same questions all the time from my neighbors coming to me as the surgeon on the block. I've got this condition, I need a specialist. Or from a primary care friend and colleague who says, somebody's going to need this specialist and they're going to need this care. Where do I go to get this operation? And what does good look like? And what is safe, effective, efficient care? What's going to be my out-of-pocket cost? There's an enormous amount of uncertainty in the way we currently practice. And it is really just our own personal experience, which may only be as good as last week and may not really be reflective of the kind of care that we're looking for that's reproducible and has high fidelity, because we have gotten so used to a transactional, very silo fragmented approach, and we don't know quite how to break out of it. Next slide. So there's been a lot of talk about transparency, and I really think this is the key. We're now just starting to say we should be transparent about the cost of care. It should be a lot more than that. We need to be transparent about clinical outcomes and separately about the patient goal attainment. The clinical outcomes are those outcomes I know as a physician. In cancer care, I say that stage 1 should do this, stage 2 this, stage 3 that, or in somebody who's undergoing total joint replacement, I would expect a certain outcome to occur. But patients have goals too, and their goals actually take into account a lot of their social determinants. They know they're living in a certain environment that may not be the mirror image of the Mayo Clinic or the Cleveland Clinic or MD Anderson. And yet they've said, my goals fit my environment, and this is all I'm looking for. But we don't lay that out there. We don't spend a lot of time determining what is their specific goal. It is a momentary conversation, and we don't really focus on it. Now, as a backup to those first two, I look at the IOM STEEP. Is it safe? Is it timely? Is it effective? Is it efficient? Is it equitable? Is it patient-centered? And if you put those three together, you've got a very powerful expression in transparency. The other part about all of this is healthcare is, patients are complex, care delivery and care pathways are complicated. The care environment and resources in which we work they're chaotic. So if we do not certify and verify that entire care pathway and the care team and how it all fits together, it just is by happenstance that it just works out in many instances. We know from years of trauma data, of cancer data, of having verified programs, not just verified bricks and mortar, but clinical programmatic care, that it makes a huge difference in the outcome of care. We've seen this effort in maternity care recently as we have a maternity care crisis. We're verifying maternity care, that it meets certain standards. There's an effort of bringing that team together. And if you don't have that, you really don't necessarily know that they are clinically ready, that they can handle the curveballs that come at them, that they can do a rescue when the rescue is needed, or they're set up with the right transfers. These are elements, these are the core elements to me that then form the linkage between helping a primary care ACO or MA plan determine where to get care and who can establish themselves as saying, we think we're good enough to perform in this environment and we think we're worthy of that referral. Next slide. Value-based care also, in a sense, it's been hijacked by the payer community as if the payer knows the judgment. Value is a judgment. What you value and what I value may be different. What a patient values in one environment may not be what they value in another. We look at this as value-based care is the judgment that reaches that patient's goal of care. The goal should be personalized, represent the patient's wishes in their environment, in what they expect the care delivery system to give them, with advice and guidance from their PCP and specialties. And we think this is actually the crux of care coordination. When the PCP and the specialist come together around the patient's goal of care, this is the communication we want to know, where the handoffs are and who's got what role to play in optimizing care. If it's separate from that, if we push them apart from each other and just say we send each other notes back and forth, or we shared a common platform with information, we're still fragmenting care. We're not spending enough time focusing on the patient's goal jointly between the PCP and the specialist, and that's really where it comes together. We spend an awful lot of time on adverse event metrics, which, if you look at them on a broad scale, then the country in general is pretty safe in its healthcare. And it's not distinctive looking at adverse event metrics, even though they are rare events, to actually determine one place is good for the outcome of care or the patient goal attainment score. There is some variability there, but it's not that great. It won't show you a distinction in care, and volumes aren't high enough to have confidence. So to achieve value, PCP specialists and patients have to openly share their goals, the true outcome of care, and be transparent about that level of goal attainment. And you can throw cost in there too. Next slide. So when we look at this within the College of Surgeons, we've got decades of collecting risk-adjusted outcome data and looking at all these adverse events. And you can see from the scoring on the right, I know it's a little tight and hard to read, but everything in red, those are bad outcomes. The yellow, not so great, and the green, pretty decent. And you can see they're rare events. You're not really measuring, did I achieve the patient's goal? Yeah, the patient survived. There were no adverse events, but they came to me for a joint replacement, or they came to me for treatment of an aortic valve. And did I restore to them their life, their quality of life that they were seeking, even though I didn't have any adverse events? We don't measure that, and we don't set it down with an agreement with the patient. It's a verbal action that we share together, but we don't hold each other accountable to that. And that's actually where patients come to us. They don't come to us to say, I don't want DVT. They come to us to say, I want this problem resolved, and I don't want DVT in the process. Next slide. So patient goal is care. I'm overemphasizing that, but it considers really a lot of other factors. Their severity of illness, their underlying comorbidities. Patients have a pretty good sense of this. And of course, they want the best out of the worst circumstances, but when you go out and when you interview across a state or across an environment, they understand where they are. They understand where they live. They understand the sources they have. When I look, and I've done a lot of looking into total joint replacement, and I look out into rural or somewhat remote areas, they can get their knee operation somewhere, but they have no physical therapy. And if you have a joint replacement, the only thing that really matters is getting through that physical therapy and restoring your life. So we're missing the key part of completing their care. We're performing a portion of the fragment, but we're not putting the whole thing together. And part of that gets to certifying that this care team provides the entire system of care, all the processes, is tracking all the points, looking for the failures. It's programmatic approach to care. It's not measuring a surgeon, measuring an anesthesiologist, measuring a cardiologist, measuring another specialist. It's about measuring a patient and saying, did we put all the moving parts together and achieve which we sought to achieve, and hold each other in shared accountability for that. Next slide. So when we look at this, what we're hearing in the episode environment, and we think it actually is, it resonates with physicians in specialty medicine, is that patients are looking for one episode price. Yeah, the clinicians and everyone else wants to singly bill for all these things, but put that aside. Understanding one episode price, all the clinical services that are involved, a team, whether that team is integrated or it's built upon a community of available resources, but bringing them together in a team and putting the patient goals, safe, affordable, satisfactory care first. So define the episode, set the team, verify that the team meets the clinical domain and has the readiness to perform. Be open and transparent about the key performance indicators, which to me is a safety profile, goal attainment scores, clinical outcomes, ready access, timely access to care, affordability, and understanding the patient risk profile environment that you treat. Do you have the ability to treat high-risk patients or not? Next slide. So just a moment, sorry, sports analogy, I apologize, but this helps make the point in a little bit of a thought exercise. Imagine you're the owner of a sports team, whatever it is, soccer, hockey, baseball, volleyball. In my instance, it would be an NFL football team. I get the best quarterback. I've got upper tier running backs. I've got Hall of Fame tight ends. I got great linemen. I put together all this raw talent. But until we sit down and come together and push ourselves and hold ourselves accountable and measure our team outputs, you've also got to have a coach. You've got to set schemes against the opposition. In our case, it's a disease or a condition, or it's the limitations of the resources in an environment. Putting that together in a system of care doesn't fit within the fragmented environment in which we practice. But it is how most physicians in their practice prefer to live. And yet they get measured in their individual fragmented areas. And we wonder, why is there burnout? Because they're not putting themselves together to say, let's work for the best benefit of our team and put this together. So that's a missing portion. When we verify and put a team together and come into a site and do a trauma verification or a cancer verification or a bariatric verification, there is a sense of pride from the nursing staff to the house staff to the C-suite to the clinical team in the OR that they've all pulled together and they know they have a role to play and they hold each other responsible for that. Next slide. The other thing, and this is just a brief mention of this, and we could go on forever on this now today. Excuse me. The concept of AI, of knowledge management, of shared knowledge management, of digital platforms is a current reality. We're still living in the EHR world. We're barely leveraging the HIE world the way we should. But what really needs to come together are digital platforms that have shared knowledge about a program of care, whether it's chronic care management for a PCP or it is specialty care management of an acute problem. We now have the capability of generating shared knowledge for all of us, patient-facing, payer-facing, PCP-facing, specialty-facing, so that we create the right shared knowledge environment. And we're not investing near enough in this. We're seeing this come from outside of healthcare, people coming into saying, gosh, we do this in every other discipline on earth. Why aren't we doing this, for God's sake, in healthcare? where this affects every one of our lives. We're starting to see it happen. But to take the engineers and the clinical teams and the patients and put them together into a knowledge environment means we all have to take time. We have to invest in that, and we have to build it. And that is the exciting future, but that is the third horizon. We're not quite there yet. We're relying on folks like Epic and Oracle and Apple and Microsoft and AWS to do this, but they need the clinical engineer marriage, the patient inputs to determine how we'll pull all of this together. Next slide. So I took some of this and I ran it through my own AI engine, and I said, well, what if I got rid of hospital compare and physician compare? And I did episode compare. So I pulled up cholecystectomy in an artificial environment and put in, you could draw in a zip code and set the mileage distance you wanted the patient to have to travel. And that could come from the patient themselves. And up pops, in this instance, 2 hospitals, the Central State Hospital and the Regional Medical Center, all of which are just synthetic artificial. But it gives you what is their price point for a cholecystectomy. It gives you their safety profile, their infection rate and readmission rate. It tells you about their high-risk patient profile and their overall patient rating. But that's not enough. We want more than that. Next slide. So we drilled down a little deeper. Now I shifted from cholecystectomy to total knee, just to give another example. But we still get a picture of a hospital, and this one has attained a level of verification that calls it a center of distinction. It's a high level, high verified place. It outlines the common care pathway. So a PCP can see this, the ACO can see this. These are the expected events that are going to occur in this particular knee replacement environment. And it is the common event. So now we can also look at volume. We can look at, and using risk-adjusted modeling, expected cost to observed cost, and get a sense of 20% of this particular practice deals with high-risk patients. And you can set that bar to deal with particular patients that might not just be high risk, it could be dependent on social determinants. So there's other ways to look at this and create an environment in which the PCP, the ACO, the MA plan, everyone can look at this and see, this is who I am as a delivery system for this episode of care. Telling me who I am as a hospital is just, it's too blunt. It doesn't give you enough. It tends to reflect the culture. It tends to give you a sense of this, but the programmatic approach is what, as a patient, I'm looking for. And then as a physician, I can go out there and turn to the PCPs. I've received a certain status, and here are my data that show this, and this can be live and tracked and updated on a regular basis. We don't provide this level of information to our teams now, and yet it's not that far away, and we should. Next slide. So if I dealt in one more little bit further, I could look at the verification, and the minimum standard is Joint Commission. But here there's verification for advanced hip and knee replacement, a higher standard that is existing in this environment. The quality metrics give you the standard safety profile, the complication rates for 30 days, infection rates, readmissions, 1-year joint revision rates. Those are the kinds of things that give you a sense, but then that real important area of patient outcomes, where the patient goal attainment, was it met, exceeded or not, the patient overall experience, and then the clinical outcome, which in this instance is a score that we can actually achieve. Was there an initial score, and was there a 100% improvement in that score? And in this case, there was. So you can see that we can actually create a very simple dashboard or report card that gets to episode compare rather than individual physician compare or individual hospital compare. It's giving the patient the kind of useful information they need in making a decision. And really, the reliance on this is the PCP, because most patients can't translate this. But PCPs, this is native to who and how they operate, and they would have no trouble helping their patient through this. Next slide. So I thank you for the opportunity to participate. I hope I gave you a little bit of a glance at the third horizon that's out there, and I look forward to the conversation. Thank you very much.
Well, we thank all four of you for those great, robust presentations, but it's now time to move to some questions. We have 10 minutes. So I want to make sure that the committee has a chance to put up their name plates and get some questions in from the committee. Krishna.
No, thanks all. Great job presenting. You all spoke about data sharing in some form or the other there. I've spent probably the last 10 plus years trying to like work through data sharing from the Epic side and of course provider and the payer side as well. I know it's a hard, gnarly problem. I guess I'm curious to see if you all had just like best practices, lessons learned from your time in the field. Like what are ways we can sort of integrate better data sharing between sort of specialists and primary care, particularly in less integrated settings?
What I can start, Krishna. I think, I think in the prior panel, we highlighted the challenge, right, in terms of we don't have unified structures in place, right? And so my chart, I've got things set up in a particular way. I can send a feed over to your chart, but it's not all the same field. It's not going to map the same way, and that leads to confusion. And unfortunately, probably leads to more medical errors or rework at that point in time. But I think the tools are getting better, right? That starts to clean that up. And the more sophisticated organizations are obviously able to create those filters and that transformation logic as that information is coming in. At least we've seen for smaller practices on average, the nephrology practices out there are not big, right? So there's 3 to 7 physicians. And so the capability to be able to provide that middle layer, right, to be able to transform and homogenize, I think starts to become really, really, really important because just sending the information, even if it's as stale as a PDF or subjected out into very structured data fields, we are finding that again, it's those smaller practices are unable to ingest them, and definitely not ingesting them into the workflow in the right spot to engender the types of behavior change that we would like for folks to happen. Even though, as you sit every quarter and collectively look at reports and dashboards, everyone's nodding their head and saying, yeah, wow, we should be doing something about that. In my area in particular, right, we always think about crash dialysis starts, right, things that shouldn't be happening, and yet happens on a very regular clip. And so I do believe, hoping that our technical vendors, evolve standards to be able to promote greater interoperability. I think it's sort of waiting for Godot a little bit at that point in time. I do feel like it's incumbent upon folks that are trying to bridge the specialty primary care gaps for smaller practices. Someone needs to make the investment that the standards are not there, and it has to start to create those kinds of homogenized reports that are clinically meaningful and relevant. And I see vendors jumping in doing that left and right because the overall industry is not quite there yet.
Any others want to comment on that? We have other questions. Anish?
So I've heard quite a few different options on how we can integrate primary and specialty care. If it's a fully integrated system, then it's a closed system. For those that are not fully integrated, having robust primary care and then using specialists only when really needed, right? So that last mile, and then conveners or partners like Somatis coming in and helping folks out. The other model that I've seen come into play recently is proactive e-consults. So instead of relying on the PCPs to send patients out to specialists, the specialists are actively, the risk-bearing entities figuring out which patients need specialty care, but then the specialists are actively going into the PCPs, EMR systems and managing the patients concurrently so that there isn't that, delay, et cetera, of care, and the care is integrated within that PCP's EMR. I would love to get whoever would want to answer that question or comments on that model and where that fits into the fourth bucket of different ways of delivering specialty care.
Why don't I push this to Rob first?
Yeah, well, so I love the idea of e-consults. I think it's a really sensible way to move forward. There's some companies that do this. There are also some health systems that have essentially set up internal processes where their PCPs can do e-consults or this. I hadn't heard actually, Hanish, what you had talked about the specialist kind of walking through the medical records and looking for opportunities. It was more that they were creating a resource for primary care to go and ask questions when specialty related questions come up. I think the real issue is being able to have it happen in a very timely way, preferably either when the patient's in the office, or you could do asynchronous stuff as well. But I think it's a good idea. The question is then, how is it paid for? I think it has to be something that the organization feels like they're getting value from it. I know that there are some new, for example, in Making Care Primary, some new e-consult fees. It's like $50 for a specialist, right? And, I just was at the dermatologist. I was there for 10 minutes and $500 bill. So I have to sort of figure out how it's financed or whether it's internally financed, but I think it's a great idea.
Other comments?
I'd like to just add one thing. I agree with everything that was said. We ran a sort of Center of Excellence program for about 8 years on behalf of our members. And first of all, totally agree on the e-consults. But one of the things that we really identified that was critical to success, to your point, was the appropriateness of the procedure in the first place. And most of the time, well, a shockingly large percentage of the time, it wasn't even needed. So having the referral or really not be attached to any incentive to do the procedure was very important, whether that's a third party, whether it's primary care, but just really separating that incentive from the consult was very important.
Frank? Any comment?
Yeah, I mean, what I'm seeing is a little bit different. And it gets down to pulling in the data and doing predictive analytics on a population and helping the PCP understand, here's your population, here's where they stand and what's going on with them, and having the specialists at the same time be able to assist and look. And they may be able to say, my gosh, we've fallen behind in mammography screening, or we're behind in colonoscopy screening. Then the radiologist and the endoscopist have to step up and help and put incentive in play in that system, that PCP isn't the only one looking at the dashboard, that those flags go out to everybody involved. This is a pop health issue. We owe it to our population to get this done. Now let's step up and get it done. And we also had that ability to look at a population and generate the predictive analytics too, and say, gosh, if all these people had this much care, this is how much we're going to save, or this is how much better we're going to improve quality of life. Those predictive analytics through AI engines are going to be here probably within the next year and a half. They're already in play. We just haven't put them in front of the PCP and the specialists, but it's coming, and it's coming fast.
Joe?
Yeah, the only thing I'd add, Anesh, is I think if you have a loosely integrated system and you have a PCP that's potentially capitated, thinking about that, and a specialist that's on fee for service, that relationship, I think, can also be challenging if you have that transparency through and you're allowing the specialist to jump in, particularly because not all PCPs have the same range of things. If it's something only a specialist can do, a little less friction, they begin to overlap, then you start to say like, there's some conflict there on who's actually providing that care. So the proactivity I love as a PCP, want to encourage it, but then you got to get that information back. If they're proactively doing it, I want to get that information back as the PCP. I don't want to wait a month or two for whatever you found along those lines. So there's a lot of other pieces together that needs to complement that.
I think Lauren has a question. Or Jim. Jim.
Hi, thank you for your comments. I had a question for Elizabeth, and then maybe if anybody else wanted to comment. I was struck by your comment around 13% savings in total cost of care, if I heard correctly, for every dollar spent in primary care. And I was curious how your members thought through the idea of what inflation rate target were they really interested in achieving in these new initiatives? And are they discussing guardrails to protect from too little care versus too much care? Is there a guardrail discussion? So it's an inflation rate target. Does that part of the conversation with your members? And what is that? What's it tied to? What's it pegged to? And then guardrails.
That's a big question, and my answer may sound controversial, but it's not intended to. Most of our members are looking for flat trend, right? They are spending billions and billions of dollars and believe that while they are happy to spend a large amount for high quality care, there are savings possible. So that said, many of them are managing to like 1% to 3% total cost increases year on year. And I will say, going back to the Office of Healthcare Affordability in California, that we have set a 3% target, but that is across the system. And the idea is that maybe that comes from, PBMs, pharmacy, health plans, and hospital care, but that is reinvested in primary and mental health care, just as an example. So I don't know how to exactly translate that to an inflation rate, but I would say that they are looking for, flat to very low trend. And of course, that is in contrast to the double-digit increases they're getting now. So there's a long way to go. Does that answer your question?
Yes, you answered it. And then just the other protection on downside, the protection of too little care for
well, that is certainly. So that was sort of really going back to the measure set that we talked about. Again, it's not the end all be all measure set, but it's about outcomes. We have an access metric. Actually, one of the biggest barriers we're seeing now is like not even being able to get an appointment for primary care, or maternity care, or mental health care. So there are major access barriers that aren't even being measured. And so they are asking that those be measured. Those are part of the performance guarantees. So, and I know access isn't the singular metric here, but outcomes, experience, they're absolutely looking at clinical outcomes. So again, it's not sort of a restriction on care. On the contrary, it is trying to get more people into better care sooner, and they are measuring that.
Krishna?
This one's for Elizabeth. Elizabeth, this is about multi-payer alignment, obviously a topic close to your heart and my heart, given our work together in California. I was wondering if you have thoughts on just like how do we export this to other parts of the country? Like, do you have any words of wisdom or lessons learned or best practices you've seen? Obviously, it just kicked off, but it took like multiple years to even get to the kickoff point in California. But any thoughts you'd want to share for us?
Krishna, I think you should be the national evangelist for this. I think it takes a lot of convincing, because I think currently, and again, I'm just speaking from my own experience, a lot of plans see this as sort of a competitive disadvantage, whereas we think they should compete on other things because, a slightly different measure set isn't really bringing a ton of value anywhere. And it really took a long time, as you said, 2 or 3 years to get to alignment here, in part because it goes against sort of current business, how teams are structured. And frankly, the muscle memory of fee for service is very strong, and really convincing folks that this can work took a lot of time. There isn't a well-funded infrastructure at the regional level or community level or anywhere really to enable this consensus collaborative work. It is, I know CMMI has tried this, but it sort of missed the mark of existing relationships on the ground. I think California is uniquely advantaged because we have groups like the California Quality Collaborative, IHA, other sort of tables where this can happen. But I think it just takes a lot of, old-fashioned time and relationship building to see the mutual benefit of this. But I would love to export it, and I'm happy to partner on doing that.
Thank you.
Lauren?
Just building on that, Loved your presentations. I'm doing a lot of work in California, so and see that native organizing that's happening on the ground of all of these new roles with community health workers and others and new payment sources, but also work nationally. And one of the things that I've seen as a trend that's been interesting is payers are starting to fund that integrator role. So it's different than an MSO. They're funding integrator roles to bring the community together for all payers, look at collaboration to meet the needs of complex populations, and then also work on the gaps in the system of care in the community to actually work on building out resources that are not there. So I'm curious if you're seeing that as well in the work that you're doing and where you think that funding may come from in the future if it's not from CMS.
Is that directed to me?
I think any of you. It's interesting trend.
I'm happy to start. Certainly don't need the last word here. I used to run a national organization of regional health improvement collaboratives, and there were various tables in various states and regions funded somewhat differently. I do think there is a role for payers to contribute to this and say, okay, maybe it doesn't have to be my model. Maybe we can contribute to a community model. And there has been, real success stories around the country of that working, not just in California, but there is not an obvious funding infrastructure for that, which I think is a big challenge nationally. And I think, I had lobbied CMMI many times to sort of contribute to that, but I think we still need to keep looking for the right funding source because right now it is not consistent.
Any others with comment? I think we have one last question, Walter.
Now I have a quick question for Dr. Opelka, something he brought up that I really hadn't heard before, which is integrating a patient's goals of care into the measurement of value-based care. So, just for background, I work in a nursing home and so do other providers in my group, and we are very focused on value-based care, but feel like a lot of the quality metrics like mammography, for example, are not applicable at all to our patient population, and yet we're asked to subject our patients to them because of the universal measure set. So I guess, is there a way to integrate patient goals of care into value-based care measurements of quality in a standardized way that's not gameable, but on the other hand, really does take into account patient goals of care?
Thanks very much. And I share the same challenges and concerns you talk about. I recently went through an operative procedure, and pre-op I had 6 different visits, and on 6 different visits, 6 different doctors asked me if I'd fallen in the last year. So I'm going to get a t-shirt that says I have not fallen in the last year. But that's how crazy the measurement system is. It's kind of nuts. And nobody asked me what my goal was until I asked them, does anybody care what my goal is? And it was a knee replacement. And I told them, I really don't want to fatigue on the back 9 anymore. I want the pain to go away. And that's my goal. So I'm measuring them based on that goal. The NCQA has just put out a goal of care measure. It's a primary care measure, but it should be changed to also consider specialty care, because all of us have a goal of care with our patients. And it's a relatively simple, it's not one of these 50 question surveys. It's a very brief survey. I think that this survey, and we're looking at this in surgical care, I think there should be a pre-op survey. What are your goals? Let's lay it out on the table right now. And then there should be a post-op survey. And for some of these conditions, there may be a need to update that survey at 6 months and 1 year, because the ongoing events related to the care you received are still evolving. And particularly in things like maternity care, where, my gosh, this is an 18-month event at least, if not 21 years or more. So there's a lot of this that is important to all of us in the way we practice, and yet we've never put it into our measurement structure. And it's probably much more eventful and informative than the way we're currently measuring. So I would make a big investment in trying to do this because we think it actually will deal more with burnout than anything. Measuring the right thing, measuring our ability to achieve the right thing is really what the nurses, the housekeeping, the surgeons, anesthesia, everyone got in this business to do, not just to measure the safety profile that and adverse events. I'm not saying get rid of those. I'm saying let's get something that's a little more pragmatic for the purpose that we serve the patients in the community.
Well, that's a perfect note to end on. On the behalf of the committee and our audience, I'd like to thank each of our panelists and presenters for their insight and excellent contributions today. We so appreciate your time and expertise. At this time, we're going to probably take a very shortened break, maybe a couple minutes, and then the committee will reflect on the day and discuss some potential comments and recommendations for the report to the secretary. Thank you. We're on a short break.
Produced by the U.S. Department of Health and Human Services.